Welcome back, everyone, to our House Call series, From Confusion to Clarity. We're wrapping up our conversation on concerns and confusions. Barry, so we talked about on our last video where we saw signs outside of Canada, warning signs that something wasn't right. Today I'd like to talk about little things that were closer to home, what we actually saw in Canada that were warning signs to us. Was there anything that bothered you in particular?
Well, we spoke in a previous ethics video about the importance of transparency, how critical it is. And I've done some ICU work, and I was a little surprised when the official mantra was that we needed more ventilators because that was going to be the rate-limiting step. But having done work in ICUs, I know that the rate-limiting step was not going to be the machines, it was going to be the personnel. I'm sure far fewer than 1% of physicians and 1% of nurses would feel comfortable managing a complex sick patient on a ventilator. So my sense was it was going to be the human beings operating those machines, not the machines themselves, that would be the rate-limiting step. So I thought it was a little disingenuous to say more ventilators was going to solve the problem.
And for somebody like me that's never even heard of the word ventilator really, brought into the public scheme so much, do ventilators really work safe? Like, are they safe to cure patients?
Well, they are safe, but again, like all medical interventions, they can produce harm.
Okay.
They can irritate the airways, they can allow infections to get in the lungs, they can do what's called barotrauma to the lungs, they adversely affect the blood flow to the heart. And, because they require a lot of training, you don't want someone who's not well trained operating these. In fact, people often forget that oxygen itself can be toxic, and so managing the oxygen concentration we give to patients is actually vital. But the truth is that ventilators, contrary to what a lot of people may think, are not therapeutic in themselves. They do help to provide oxygen to the body, while whatever problem that required the ventilation to do the job instead of the lungs is fixed. So, for example, if you go into severe heart failure, we may have to ventilate you. But if we don't do something about the heart failure, the ventilator will not fix that. And that's why we saw, for example, early in COVID, when we had no treatment for COVID, the mortality rate for people on ventilators was very high. International levels were 80 to 85% mortality rate. And the few people who were able to survive took many, many weeks because they had to do it on their own. And all the ventilators could do would buy them time in the hope their own immune system could fight it. So the mortality rate was very high because ventilators themselves are not therapeutic.
Most people don't understand this information. I think unless you're in the medical field, people like myself and I'm sure many of our viewers won't understand this.
I agree, and certainly I became concerned about some of the unchecked emotion out there. I remember hearing from the West Coast public health officials saying that our worst case scenario has come about. 4 people from the same nursing home died. And I thought that was sad, but I hardly thought it was the worst case scenario. I would have thought the worst case scenario was 4 children from the same daycare dying, or 4 pregnant women in the same apartment complex dying. So I thought that was a bit emotional hyperbole. I've done nursing home work for over 20 years. And the reality is, as sad as it may be, nursing homes are where we go in North America to die for the most part. So when we saw 4 people die in a nursing home, I agree that's sad. But it's hardly shocking because that's where we go to die. In my experience, and it's been confirmed by a number of friends of mine who still do nursing home work, is that people today, when they go to nursing homes, generally are even more frail than they used to be. That's probably because we can treat a lot of conditions better in people than we used to, and we have so much more in terms of support systems for them that they can stay in their home or in someone else's home before they end up in a nursing home. And the trouble is that when they're that frail, they may not be able to mount a good immune response to a vaccine. So, for example, during flu season, we knew that even if someone could mount an immune response to the flu vaccine, it didn't mean that they would survive, because even a good immune response, if they could get one, it might only bring the disease down from an 8 out of 10 to a 3 out of 10. But when you're that elderly, that frail, have that many comorbidities, a disease that's a 3 out of 10 could still take your life.
You talk about the fact that they're in a nursing home or nursing home, that they are frail. You add stress on top of that, like it was major stress for COVID, and now they're cut off of support from their family, right, their loved ones, which is a major source of, what do you want to call it? It keeps them healthy, right, to have that contact. So now they're cut off from everybody. The question kind of needs to be asked is, did they die from other complications that arose out of being isolated from their loved ones? I would say yes.
Well, could well be. And again, another source of confusion for me was the fact that it was difficult for me to volunteer to help out,
Yes.
even with palliative care.
Yeah.
And I kept reading the newspaper, and I never heard that the hospitals in Ottawa were overwhelmed or that the ICU was overwhelmed. In fact, I remember reading an article early on when an ICU doctor said that they had a special backup schedule in case things got really crazy, but he never actually got called. He was twiddling his thumbs at home. Yeah. And I'll never forget April 8th, 2020. On March 24th, they had made a prediction based on their models that in the next 2 weeks, that is by April 7th, they anticipated in Ontario, best case scenario, they would have 800 patients on a ventilator, worst case scenario, 3,000 or more. Well, the 2 weeks passed, and on April 8th, it turned out there were 240 people on ventilators in the entire province, less than a third of what they predicted as the best case scenario. So I started to wonder, how good are their models? How good are their predictions and their theories?
You talk about modeling predictions. For many people that don't know, when they declared the emergencies in each of the provinces, they did so on the modeling predictions out of the UK from Professor Neil Ferguson. And what he predicted for Canada, he said that there would be 326,000 Canadians would die from COVID. And so what did wind up happening was 0.04% of the population died, not 0.8%. I mean, that's a huge difference. So that was the first problem with the modeling, that because it was international, we could blame it on that. But then when you look at all the provincial problems that they're having with their modeling, I mean, their modeling predictions are just outright wrong.
And I was confused as well that there was no talk about doing testing for immunity, as though no one would be immune. And as we said earlier, we knew kids weren't getting sick with it. I remember reading about Germany, one of the hardest hit areas in Germany, and the serologic test they did for immunity showed that 25% of the population was already immune. Now, whether they were already immune from previous cross-immunity to other coronaviruses, or they actually had been exposed to COVID and developed immunity on that basis, I don't know, and maybe they don't know. But the presence of immunity was already fairly high.
Oh, sorry. You know what I didn't mean to cut you off, but I wanted to draw attention to the fact, because you reminded me, like you said something about children, like little attention was paid to the fact that children weren't getting sick with COVID, right? They weren't dying from it, thank God. And so, it used to confuse me. I was thinking, well, I don't know what I'm more confused by, the fact that children aren't getting it, because I wondered why they weren't, or the fact that there was no attention paid to the fact that children weren't getting sick with it. Like nobody was making a big deal about it. It was just a sort of a non-fact, and I was thinking, well, this is huge. We've gone from one spectrum of our population, the most elderly, to our youngest population that were completely ignored until now.
Well, I agree, and again, we weren't doing immunity tests on children or on anybody else. We just stuck with a PCR test. And despite that, I had a lot of confusion about exactly how do the PCR tests work.
Yes.
How did they do them? I knew they were not detecting an intact full virus. They were detecting some part of it. Was it the spike protein, some other part of the envelope, part of the RNA within it? Was it a screening test? Was it a fully diagnostic test, a confirmatory gold standard, as we'd say? We knew that it was also the polymerase chain reaction magnifies the presence of small bits of the COVID virus. But if you magnified enough, then you may detect something so small that is clinically insignificant. And if it's detecting a part of the virus, not the intact virus, could it be detecting a part of that virus which is the same as a part of a different virus? In other words, could we be getting false positives? But again, I never heard about what the specificity and sensitivity of the PCR test was.
I know we're going to cover that in extensive detail on the Follow the Science videos that we plan to do. And so even the name, false positive tests is confusing to people. Which one is it? Is it false? Is it positive? What is a false positive test? I mean, it's ridiculous.
Yeah, and equally, we put cases and deaths out there alone without any kind of perspective. So we had no idea, well, how many people would normally die in car accidents, or lightning strikes or heart attacks or etc. It was just an isolated number, and without some kind of perspective, it was hard to know what to make of it. And unfortunately, when you put things out of perspective, it tends to increase the fear. For example, lately we're talking about 10,000 cases of COVID diagnosed per day. Well, the WHO, the World Health Organization, says that their estimation is that 1 out of every 7 people in the world gets the flu every year. Well, a country of Canada, 35 million or so, means 5 million people. And since the flu season runs from kind of early November to late March, more or less, for simplicity's sake, that's about 5 months, which means we get 1 million cases of flu every month during a typical winter. Well, that's 30,000 cases per day.
Typical.
So we're used to 30,000 cases of flu, but when we hear 10,000 cases of COVID, we have no perspective unless we know that number. And also with COVID, we've tended to kind of accumulate data over 2 years.
Yes.
So all the deaths from COVID, whereas with flu season, we just say the flu season for this year versus the next year, not both years combined.
Yeah, exactly. And so when you talk about the accumulation of deaths, it's true. The government and public health are just accumulating the death toll for COVID from the beginning. And it's actually an unethical way to report it. Like Statistics Canada does the reporting from January to December. And so you do that in order that you can compare that same time frame with another time frame. You're then comparing apples to apples.
Yes.
If you leave like a running total like that, it's very misleading because it gives it the impression that there are more deaths that are really being happened.
Yeah, and I must say, one of the things that confused me the most at the beginning was that very early on it was stated we can only rely on the vaccine to get us out of this.
Yeah, I remember.
And I'm thinking to myself, there's HIV, herpes, hepatitis C that have been around for decades now. We have yet to develop a vaccine for them. We never developed a vaccine against SARS, MERS, or any coronavirus. Why are they so confident that despite all of that, they'll be able to get a vaccine for this one? That seemed bizarre that they're putting all their eggs in one basket. Then to make it worse, there was no talk about treatment, only vaccines. There's no treatment. And I'm thinking to myself, gee, there are 10,000 drugs on the market. I wonder if it's possible that one of those drugs, which we know well, we know the dosage, we know the safety, could they be at all helpful? Not necessarily cure things, but at least reduce the morbidity and mortality. The example I would use would be, imagine you're on a boat in the middle of the ocean, and it develops a large hole in the hull and it starts to sink. Well, someone might well say, look, I know a guy on shore who can fix that hole in the hull perfectly. Well, great, we'll try to get a hold of him. Hopefully he can make it out here in time before we sink. But don't you think if you're on that boat, watching the water come in the hull, that you might want to find some other solution in the meantime just to stem the flow of water? Wouldn't you grab a sock and stuff it in there, or your cheese sandwich, or anything you could? As long as it wasn't something that made it worse, like a grenade, you'd probably try anything you could just to stem the flow until they came from shore to help out.
Exactly.
And yet we didn't do that with COVID. I was just shocked that no one was looking for treatment when we have 10,000 drugs on the market that we could repurpose for this, to fight this virus.
Yeah.
And I thought the World Health Organization was prepared for that. And, I kept thinking to myself, there are 500 cities in the world with a population of 1 million or more.
Yes.
Which means that if even only 2% of each population of each city got really sick and needed treatment, that would be 20,000 people. So we could take 500 of those 10,000 drugs, assign one to each different city, over 1 million people, and we could do a study in, say, 3 months that would involve at least 20,000 people. And at the end of 3 months, we might have some idea if any of those drugs would be helpful. Not again to cure, but at least slow down the rate of death and mortality. And yet, that wasn't done. And if only 1% of those 500 drugs actually ended up being helpful to some degree, we would have had 5 drugs we could have used to reduce morbidity and mortality. And yet it wasn't done. And I cannot for the life of me figure out, why didn't we do that? Why was it all about a vaccine off in the distance and really so little effort to find a treatment in the meantime? And in fact, if people brought forth ideas, they were poo-pooed right from the start almost.
Yes, yes. We could talk for hours about all of the inconsistencies, like all of the concerns, the confusions, and they really are inconsistencies.
Absolutely.
We actually found 19. We documented 19 of them, oddly enough. 19 inconsistencies that do not support the COVID-19 narrative. I'm going to put a link for everybody at the bottom where they can find it on our website. I'll do that in the detailed description of this video. Thanks very much, Barry, for talking about our concerns and confusion.
Thank you, Paula.
It's a subject that is very interesting.
Absolutely. I've enjoyed it.
Thank you very much. Thanks very much, everybody.
Thank you.